This is the Aware Families Podcast, the show that brings you a science-based, practical look at how to use the principles of functional medicine to keep your family healthy. Welcome back to, I guess it's podcast number 11 of the Aware Families Podcast.
Yes, episode 11. We're here.
Yep, we made it past 10. Woohoo! And so today, I'd say welcome back for anybody that's kind of new to joining us. I'm Tom Flass.
Yep, and I'm Brittany Coburn.
And we're your hosts and also the providers at Functional Medicine Associates of Montana, our functional medicine clinic here in Kalispell, Montana, which is also a recording studio.
Yes, yep, double whammy.
Mm-hmm. So today, I think we're going to kind of hit it a little bit differently and just sort of maybe do a little more riffing on a subject, but really I think actually getting to the meat of what we do a lot of.
Exactly, right? Turning regular medicine on its head, kind of upside down, and explaining what it would look like if you were going to come and do a visit at a functional medicine practice, particularly the one we have here in Kalispell.
Yep, but and you know, obviously there's so many different types of conditions that we see and things like that. So we're kind of going to look at just sort of what a health assessment, or you know, whatever you want to call it, a checkup. Yeah. And you know, what would be, I guess, traditionally like your annual physical type of thing, but from more of a functional medicine perspective.
Exactly. Because I know I get a lot of questions about what is functional medicine. And, you know, we talked about that in an entire episode, right? So I think
episode numero uno.
Yeah, number one on, you know, what is functional medicine. But then I also get a lot of questions just about, well, what does it look like? What do you do differently? And, you know, why should I be looking at these different kinds of labs? Mm-hmm. So, us having this conversation and kind of talking through that process makes a lot of sense to me.
It'll give you a gestalt of kind of like why. Yeah. I mean, and there's certain things that are the same. And again, we don't throw you and I are both, traditionally trained Western medicine providers. Yep. You know, we don't throw the baby out with the bathwater. So there's the good side of quote unquote Western medicine, which I think is, what our training speaks to is looking at the recognition of illness, like knowing sick versus not sick, and warning signs and that clinical experience, understanding things like pathophysiology, pharmacology, anatomy, disease presentation and progression, really
learning, you kind of mentioned this, but really learning the difference between normal and then what is outside of that range, right? What is outside of normal limits. Yep. And you need experience. You need years of experience to really embrace that.
When is it time to phone a friend?
Exactly. Reach out for help.
Because, that's one thing we always talk about. We don't cowboy stuff here. If there's something that's, above our scope or where it's like, okay, this is some serious stuff going on, we need to add to our team. Exactly. We need to pull some other people in. So.
And we don't, we have team members that are in conventional medicine.
Absolutely.
And so, that is still something that we very firmly believe in. And I think that's an important aspect to continue to.
It's not an us versus them.
Correct. No, we're together, and we just want to provide that team approach to really looking at, full health and health span, right? Yeah. Not just lifespan. Mm-hmm. So I know that's something that I talk about daily, is understanding what health span is. And, I think that our workup and our approach helps to get to that health span versus just living.
Or, some just paltry damage control kind of thing.
Right.
Which is kind of where a lot of medicine has gone, through no fault of a lot of the providers, but just the system. That's a whole nother conversation. Yeah. Where the setup is, I think against the patient and against the provider, there's only a couple people who are winning at that game, and it ain't the providers and it ain't the patients. So.
Right, because the providers want to spend the time, they want to do what they need to do, and they're often not feeling like that's a choice.
You get kind of limited. So, and just I was thinking about this too. If we sort of your training, kind of just run through that. I know we did that in episode 1 too, but kind of like where you think that got you some advantages with your training.
Right. Oh, I think it's huge. So I don't think you can underscore the importance of having conventional medicine training, right? And so I'm a family nurse practitioner, did my education or my higher education through Montana State University, and had a great deal of exposure to medicine, both in inpatient, outpatient, right? Just kind of like across the spectrum. And then I've had 15 years of practice.
Then you got thrown into the fire.
Right. Yeah. Well, that's the other thing. And so you go from, learning and doing everything to then practicing, right? And even when you're in the education realm still, so in clinicals, like maybe before you're even out on your own. So your residency, we call it clinicals, where you are working with patients, but you still have that backup help, right? And then all of a sudden you're
live without a net.
Then you're on your own and you're like, and I was blessed. I can say this because I started in a practice with some amazing providers that I was able to ask questions of and kind of be that backup net for a long time. I could not have imagined it another way. Still feel super lucky. And I also feel lucky because we are kind of in this old school realm where we were more rural. And so we did a lot.
Montana medicine is different.
It's different medicine. And so we saw a lot of different things in the clinic setting that you would never see in a clinic setting in other areas. So, and we were able to take care of it and do a great job, right?
Just makes me think. We've been watching 1883, and then we just are finishing up 1923, which is that Taylor Sheridan series of the precursors or the prequels to Yellowstone.
Oh, okay.
And so in 1923, there's like this country doc in basically based out of Livingston, serving all these like ranches, and he's it, right?
Okay,
this guy is it.
There you go.
This last episode, he has to drill a burr hole in this guy's head who has a brain bleed.
Oh my gosh.
With like stuff they salvaged out of the barn.
Oh, for
kind
sure.
of stuff. And so it's like, that's Montana medicine.
Yeah. It's not that far off, right?
Yeah.
So I like I said, I feel super lucky that I had all the experiences I had and was able to work with some really phenomenal providers. But again, eventually over time just found that I wanted to do more and I wanted to work and do a deeper dive and really understand what we could change upstream instead of waiting for the other shoe to fall, right?
Yeah.
Yeah.
Yep.
What about you? What would you say? I know you've talked a lot about like being thrown into the fire, right?
Yeah.
In residency and what that looked like in Colorado.
And our training program. So I did pediatric residency and pediatric gastroenterology fellowship at Children's Hospital Colorado. Busy, high level Children's Hospital. And again, we got the snot kicked out of us because it was before a lot of the work hour reforms and things like that. So we were doing some long shifts, and that's a double-edged sword,
right.
because whereas it can be to the point of abusive, but I also wouldn't trade that for anything. I mean, my first year of fellowship was the hardest year of my life, but I learned so much, and you become so independent, and you're. Because it's survival mode, it's kind of like a war mentality. Yeah. And there's a plus and a minus to that. But I mean, again, that being in that and having that level of clinical exposure to all these, these things that you'd see a couple times in my career. So super lucky. I mean, I can't say enough good things about the mentorship and the people in that program and the trial by fire. And, and then I think that just sort of creates that base, and so I still use all that stuff. But then same thing, I was like, there's something more. And having that nutrition background going into that and really trying to look at the bigger picture of things, upstream medicine, things that I've always, we've been into for years, microbiome and nutrition and how does diet affect all these things. So kind of taking that base and building off of it, which is kind of what we do here.
Right. Yeah. Because that's exactly what you just said. We take that base and build off of it. So we don't get rid or negate any of that education and the medicine that we've learned. We're just really doing more kind of.
That being said, there's definitely things, especially the way the system is set up right now, that leave a bit to be desired,
right.
And are not necessarily always as customer focused. And, we talk about sort of the downsides of conventional medicine. Obviously the time constriction, where you have these 15-minute visits to try to do
solve
all these complicated things. Being, upstream prevention, recognizing things early before they get bad, I think Western medicine could do a better job.
Right. And it's something that we really, really focus on, right? Versus waiting for something to be wrong.
Like we talked about this earlier. The thing that always drove me crazy, and it's happening, where, somebody will go in, get their checkup, get the basic labs or whatever, and then maybe they're pre-diabetic. And then the advice is like, come back when you're fully diabetic and I'll put you on meds. Not like, how do we reverse this, which is fully, even type 2 diabetes, fully reversible in a lot of cases.
Right.
But just not even that recognition, or just like, let's wait until it gets a little bit worse and then we'll put you on medicines.
Well, and so much of the training really pushes the medication piece and waiting for an A1C of a certain value, right? Like, let's make sure your A1C is 6.5 and then we'll start medications.
Yeah.
Versus, what about diet? What about actually taking the time to have the discussion of breakfast?
And there are tests you can do to pick up these problems much earlier that we'll talk about in a few minutes.
I was going to say, we'll bring all of that up. But really fast, pre-diabetes, right? Just to define it for our folks is diabetes would be if you are having blood sugars that are well above the values that we want. So 124 fasting blood sugar on 2 or more occasions, or an A1C of 6.5 or higher. And those are all labs that you can have done with your regular provider. And they are usually doing those annually. We do those plus
You're talking about for actual diabetes.
For diabetes.
Yeah. And then pre-diabetes,
is that range of
5.7?
Well,
above,
it depends.
Yeah.
It totally depends, right? If you look at your lab report, sometimes it's 6.0 to 6.5.
It's always interesting that
wild
they're measuring the same thing, but what the normal range is can vary.
Yep. And right. And they change the normal range to
just like they changed the normal range for your liver enzyme called an ALT. Upper limit has always been 30. They didn't change the type of test, but because
people
100 million Americans have fatty liver disease. They're like, we don't want to be bothered with all these people, so they raised what the quote unquote normal level is. It's like, it's not normal, but it's the American normal, which is a whole.
Well, and that's how they change those ranges, though. It's wild.
Mm-hmm.
Yeah. But anyway, okay, so if we, you and I have mentioned this, and we now have quite a few podcast episodes discussing the 6 pillars, right? And how those play into your and I discussion with patients. So what would you say, very high level, that you would be bringing up the 6 pillars of health when you're doing your very first visit?
Because it's really, it informs everything else, right? So I think we get so focused, especially in the West, on the fancy stuff. And we talked about this in other podcasts. Not there's anything wrong with, looking at some of these other factors.
Right.
But I always think, like, why are you chasing like peptides and all these other things if your sleep is totally horrible and your diet is full of like processed junk and you're not doing things. Yes, you're not in exercise. You're not managing. So what are you doing? Like what are you trying to achieve? Like because that's why they call them 6 pillars. We call it the 6 pillars, right? I mean that is the foundational aspect of health. And really, if you pay attention to those things and shore those up, a lot of times you won't need those other things. I just think it's really putting the cart before the horse, trying to go for all the fancy supplements and all that, the quote unquote hacks, when the real hack is addressing those pillars. And so I try to explain that to a patient and be like, it may not be sexy, but this is really that's where the rubber meets the road. That's what's going to get you the most bang for your buck.
Right.
But and here's the other big part. It's active medicine. It's active participation in your own health versus something that's passive and paternalistic, which traditional medicine has kind of gone down that route. And again, it's not the fault of the providers. That's the way the system and the mindset is set up with pharmacology and things like that, like a pill for every ill. And, here's like the magic pill for whatever it is, and the advertising blitz that you get for things like that. But it takes that and some people want that responsibility taken away, but that's not the reality of it. Like if you want health span and lifespan, you have to take some initiative.
There needs to be a partnership.
Yes.
So, and that's, I think, how we both approach it as a partnership. Like, hey, I'm here to help provide guidance and evidence and show you the research on this. But again, you have to do the work.
Yes. And we'll help you. We'll try to give you resources, pull in other team members if you need to. That's where things like health coaches come in. Or
for sure. Nutritionist, dietitian.
And sometimes like having like your exercise partner or your diet buddy or whatever you want to call, things like that. So somebody to hold you accountable, and find out what your motivation. Because I think that's one of the things we always try to assess, like what is that person, what are their personalized health goals, or what's their why, right? Right. Always ask the why.
Because we all have a different why, right? Some of us want to do, what do we want to do? Keep up with our kids. Do we want to run a marathon? Do we just want to get through the work week, right?
I just want six-pack abs.
Yeah. Well, there you go. Y'all got to have goals.
Yeah, But unfortunately, that's where I think a lot of the quote unquote health focus has been on stuff like that. Yeah. But really, like, if you want to be able to play with your grandkids, if you want to be able to,
keep up, right? Like my kids are now 15 and 13, and they ski really fast and they ride bike really fast, you know, and I have to be in shape so that I can keep up. And I still probably can't keep up going downhill biking, but that's okay.
No,
you know,
I think we'd be doing our podcast from from the ICU or the rehabilitation facility with your, whatever clavicle fracture you had or something.
But still, the point being is, muscle is important. And so there's a lot of, people will come in too, and they're having an issue with sleep, right? Which is a pillar. And so they're like, hey, I'm working on it because I know how important it is. And you and I both know that sometimes there's different things that are interrupting and causing issues with sleep. And those are things that we can work with people also.
Yeah.
Your progesterone, maybe it's not doing what it's supposed to do.
Yeah.
Maybe
there's a place for it, the supplement or hormone replacement or whatever it may be in that particular person's case to help them along those pillars.
Exactly.
But we always come back
to the pillars. Yep. So I have every single visit, we're going to talk at least about some type of pillar or all of them, but especially that first visit.
And especially, obviously my training is in pediatric. But even from there, I'm sometimes thinking about like the how do we prevent what we call the 4 horsemen, which are like heart disease, diabetes, cancer, and Alzheimer's or other neurocognitive decline. Like, if you think of the things that are going to just kill you, they kill you and or like just destroy your health span. I mean, those are the big 4 things. There's a lot of other stuff, autoimmune disease, things like that too, that we think about. But if you're sort of, the patients that we see that might be coming in their 40s or 50s kind of for like a tune-up type of thing. Yeah. These things I think are really, they're either in the front of everybody's mind or at least a little bit in the back because of just the reality of...
or family history, right? They might be like, hey, my grandparents, my parents, my aunts, uncles, right? They might be carrying a lot of this family history with them and not maybe understanding the genetic component versus the, lifestyle component.
And really trying to get an honest assessment of where people are at and how at risk are they. Yeah. And there's things that we do in functional medicine that, again, we'll talk about a little bit in a few minutes that I think give us a little bit more insight to that instead of just some of the, and even some of the basic labs, you can, if you're looking at them the right way, you can tell some of the stuff, but there's so many cool things that we've learned through our training in functional medicine of really looking upstream, like, hey, this isn't that bad now, but based on these markers, this is a path you could go down and let's nip it in the bud now and try to turn things around.
For sure. So we talked right away about talking to patients and really understanding, what their goals are, because I think that is critical to that very first visit. And then, you and I both talk about understanding what their baseline is. So kind of where they are and, what all do we do to like determine that. And so we really will start investigating that and having that conversation from birth, essentially. Like the history, hey, how was your birth history?
What's their health story?
Yes. Tell us, okay, so you're mentioning you're coming in with this issue. How did we get here? And then we start kind of like backpedaling, right? Like,
reverse engineer.
Exactly. And we can go sometimes all the way back to birth.
Yeah.
And so it's just interesting, but that takes time, right? It takes a lot of time. And so that's why our first visit with patients are 90 minutes long, because we really want to understand how did we get here? And sometimes we pick up on things that contribute to these symptoms or this, what is going on that maybe the patient hasn't thought of yet.
Yeah. Like toxic exposures, what kind of messed up their gut microbiome along the way, and trauma. We've talked about this a lot. Adverse childhood events and trauma got informed so much of so many things that we see as healthcare providers, and it's tough because there's no quick fix or whatever. But if there's some major trauma in that person's past and that doesn't get addressed, we're still putting Band-Aids on stuff. It's I think we've just begun to really start to address that trauma piece in healthcare. I think it needs to be, should be such a foremost thing that we're dealing with, but it's tough. There ain't no quick fix.
No, I know. And I know you and I both, we do a lot of referring to counseling, both of us. And it's
trauma-based therapy.
Yes. And I just, I can't speak highly enough of the therapists that we work with. And, we often use people up here in the Kalispell area, but we also, refer down to Missoula. There's some amazing folks down there that we, like to refer to. So there's people you can do it online, right? I mean, so there's a lot of options. It doesn't have to be face-to-face, doesn't have to be in person, but can be really crucial to your healing.
Yeah. So when we're making our plan,
Yep.
depending on what we've kind of unearthed, that is a piece that we always, if it's there, we got to address it.
Yep.
Kind of thing.
Yep. Can't ignore it.
But yeah, all this kind of things. So that going through an extensive history, and in functional medicine we call it the ATMs. What are the ATMs?
Right, the antecedents, triggers, and mediators. So like what all, basically in a nutshell, what is all contributing to what you're going through now? Right? Is something
not just you have a headache, take a pill for your headache.
Right. Exactly. Yeah. But like, what are all the things that contribute? And then we, kind of put them in these fancy little boxes. But really, that's in a nutshell what it is. So we go through that, and that's the whole, that takes a long, that's the majority of the visit, honestly, is this discussion piece. And so sometimes it doesn't seem like we're doing as much of a physical exam, and yet we still are, because we're still taking note throughout that entire process of different things that are going on physically.
Yeah. And the physical exam, a lot of the, we still do the heart and lung exam, and, a lot of the
just
the
like
things
you would have done, that we learned in school, right? A million years ago. We do look at some other things, I think, physically. Like I do a lot of fingernail assessment.
Hair, skin, and nails.
Hair, skin, and nails. Your skin is your largest organ. So we do.
Not from a judgy, you need to go to like this other nail salon or something like that. But yes, there are nutritional deficiencies and other health things that can show up in I
like that. I'll make sure to be, we're not judging. Yes, it's not a judgy perspective. It's really like, are there pitting? Are there ridges? What do we have going on? Yeah. And then like your tongue and the shape of your tongue. And there's just so many different things that we can utilize that are easy, that we can just see, touch, feel. Yeah.
Yep.
But then you're right. We still do an abdominal exam, cardiac, lungs. We're doing the same thing that we have learned. And thank goodness that we've learned that and had all the practice, right?
Yep, exactly. So, and then there's some things that we'll add on to. So, for example, there's this metric that's called the BMI, body mass index, which is basically your weight for your height, which, from a very 10,000 foot view, when your BMI is really high, you're too heavy for your height. That's associated with a number of health issues, high blood pressure and diabetes and heart disease and things like that. But it's by no means a perfect marker. Right. And it's just a really, really rough assessment. And I think sometimes can be misinformative versus something what you actually, like bioimpedance, which is a measure that we are starting to work with somebody locally with that can do it, where it uses electrical current to determine your body composition, meaning like what's your like how much of your body is fat versus lean mass versus water weight, and it gives you a much more accurate number. And where is that fat deposited? Do you have it? Is it more peripheral where it's not as dangerous, or is it that central,
all around your organs,
visceral what's called visceral adiposity that is associated directly with insulin resistance, type 2 diabetes,
cardiac risk.
Cardiac risk.
Yep.
So I think these things are I wish we would use them more in all physical exams, because they can be, they're quick, they're easy, they're relatively inexpensive, gives you way more information than a simple BMI does. For
sure. A lot of the programs that people, partner with their like insurance and stuff, they bring that type of thing in. I know we used to do that at the hospital here, and I think that went away, which is sad, because I think it's such a great addition to be able to use that kind of as like that it should be just like getting your vital signs. That should be like the other piece. Because
it's a very politically incorrect term, but the TOFI, you remember that? That sort of, we don't hear that term thrown around much. So I think it was made up by a radiologist, and they were doing these MRIs.
Okay.
And he'd be like, this person's a TOFI, thin outside but fat inside. Oh, so the people that like, you do the history and they're eating horribly, drinking a bunch of soda and blah, blah, blah. And then, but they look sort of thin from the outside, but if you do the right scans, like if you did a body composition with a bioimpedance or a DEXA scan, or if you are doing like these MRIs and you can see fat versus lean mass, their internal organs are just caked with fat. And and all of a sudden you check the right labs and like, this person is a ticking time bomb. Yeah. But they would be the envy that you look across the room and be like, oh, that person can eat whatever they want and they're fine because they're quote unquote thin. Yeah. But they're so not fine.
Yeah. I had not heard that acronym. Yeah. That's interesting.
Yeah, TOFI. I don't hear it thrown around. It's probably politically incorrect. So. I apologize to anyone, but this is, you can actually look in the medical literature and it was kind of coined by a radiologist.
For sure. Yeah.
Yeah, and we've talked before about heart rate variability, using that metric.
Exactly.
Which is, we don't do it in the office, but we encourage people to use that metric at home if they have a good device.
For sure, yeah. And again, we can use that as we're like working through health with people, right? Like, okay, where are you at? What are our goals? How are we going to get there? Yeah,
and that's past podcasts we've talked about that, but heart rate variability is more measuring
an exercise.
that beat-to-beat variability, and it measures something called vagal tone, which is like, are you in that fight or flight? Are you in the rest and digest? Are you balanced in your nervous system, or are you on like hardwired all the way to the floor all the time, which is definitely associated with negative health impact and things
fight or
like
flight on high drive. So that I always say, if you see a bear, that response, it's not supposed to be on all the time, right?
Get away from the bear.
Get away from the bear.
Have a meal. Relax.
Yeah, totally.
Chill out.
Okay, so then you and I, one thing that we do a lot of here, we do a lot of labs. So what would you say, like if you had somebody coming in for, just coming in, they're like, I feel pretty good, but I really want to work on my health span, and they're in their 40s. What would be kind of a general, set of labs that you might look at?
So the real basics and the ones you typically might get for an annual physical, that there can still be some really useful things you gain from that.
For sure.
But CBC, or complete blood count, basically measures your red blood cells, your white blood cells. Sometimes they'll do what's called a differential, kind of the type of white blood cells. Just make sure you're not anemic. Make sure it doesn't either showing signs of infection or something like leukemia that will show up with an abnormal white count. Your platelet count, which are the little sort of particles in your blood that will help to form a clot, but it can also reflect, if they're high, it can reflect if there's something else going on, like an inflammatory process. If they're low, you might be at increased bleeding risk because there could be something else going on with like your spleen or, bone marrow issues, things like that. So, I mean, obviously some big ticket items like that. CBC, absolutely worth checking once in a while.
Oh, for sure. But it also is going to have like the size and shape of your red blood cells.
Yes.
So we see that a lot, when I'm looking at women, and I want to really check like for B12 deficiency or iron deficiency, especially if we're like having really heavy periods or, and you can see that on the CBC, or you can at least get a good hint that you need to be looking.
Yes.
So I use the CBC a lot.
Yeah, and if you're iron deficient, red blood cells shrink and get small. Lower MCV, B12 and folate deficiency, red blood cells get big.
Big and
if you have a mixed one, it can trick you because then you're in
it does.
Yeah.
And then sometimes you're like, everything's low.
Yeah.
They're like kind of right in the middle, but really everything is crazy low.
But you brought up a great point before. So the other thing across the board is that we're missing a lot of cases of iron deficiency.
Yeah.
Because I think there's this common misunderstanding, even in the medical community, that if your hemoglobin and hematocrit, which are the measures of your red blood cells, if those are fine, your iron is fine. But that's the last thing that happens when you're iron deficient, is that you start to get anemic. Right. The first thing that happens is your brain gets iron deficient.
Yeah.
Fatigue, brain fog.
Yeah. But that RDW that we see, right? That's another marker that I think often goes just kind of unnoticed.
Yeah.
Like it's really climbing high, and all of a sudden we're like, oh, we watched it trend, and it went from low normal to high normal, all of a sudden too high. We're like, oh, you do have all these red blood cells of different sizes floating around, right? You're not getting adequate workers out of your red blood cells because you're
So let's
anemic.
dive into that nutrition, or is there something else why you're not absorbing iron, or things along those lines. So things like that, the iron and the CBC can give you a lot of information.
And that's just a regular lab test. Like you're going to get that anywhere. And so that's what's kind of nice is that I feel like we really dive into the CBC. We don't just look and make sure they're not flat.
And I get a ferritin, which is the measure of iron in the blood. I get that on almost everybody.
I think I get it on everybody. I don't think I skip it ever.
Especially kids and pregnant women.
Yeah.
Because brain development is highly dependent on adequate iron.
Yeah.
So if you have a kid who's iron deficient in those first 1,000 days or up through toddlerhood, like if they're at risk for any reason, or if they're premature or whatever, like you got to get the ferritin. I think that the American Academy of Pediatrics, is thinking about shifting and actually adding that on. So it's like one of those labs that they automatically check maybe at the 1 year well-child check. But I don't know if that's really gone through yet, but it's certainly been a discussion, and I would highly endorse that.
Right. For sure. Well, and if you have severe dietary limitations, right, your ferritin, it is going to be reflected in there.
Yeah.
So.
Or the kid who drinks a ton of milk and doesn't eat any meat.
Yep.
And,
that's a big deal.
Yeah.
Yeah. So that is one that we both check, I think, all the time.
Yep.
So that was CBC, ferritin. And
then CMP, or complete metabolic panel, which just kind of checks. It sort of runs through like your electrolytes and your basic kidney function and your liver enzymes.
Right. Yep. Kidney function, liver function, electrolytes. And I think we all kind of look a little, we're looking pretty deeply at that liver function test, right? And so we're looking at the ALK phos, ALT, AST, and then a GGT. So often, are you adding one of those?
Which used to be part of that, but then they separated it out.
Yeah.
So the GGT is a specific enzyme more for with the gallbladder function. So, for example, if you had gallstones or you had gallbladder disease, that GGT goes up. If it's low, in functional medicine, we kind of think like sometimes if that's being used up, like if there's, I guess it can either be high or low if you have a high toxic burden, because that GGT is also a detoxifying enzyme. So that's an interesting kind of functional medicine look at that test.
For sure. And we can see it high, and this makes sense with the detoxification piece with alcohol intake, right? Yep. So if there's heavy alcohol intake, that number can go up.
Yep.
And it's, kind of a sign there.
And if the liver enzymes are elevated, there's a whole bunch of things. Most common reason why your AST and ALT, which are the two main liver enzymes we check, is again probably fatty liver,
right.
Or not. It's used to be called NAFLD or non-alcoholic fatty liver disease. Now it's what's called metabolic associated liver disease.
Right, and they would differentiate between fatty or between. Oh my gosh, why can't I think of it?
NAFLD and NASH.
Yeah, NASH. Okay. Yeah. And then, they're kind of changing the terminology now to show.
So NAFLD would just be like the liver enzymes are elevated. NASH actually means you're getting,
alcohol.
You can, it's an alcoholic steatohepatitis. So that basically what that means is like it's fatty liver to the point where it's starting to irritate and damage the liver. So if you did a biopsy, you would actually see inflammation, and you're starting to get what's called fibrosis, which can eventually lead to cirrhosis, which is bad news bears.
Bad. Yeah.
So,
which we are seeing, we're seeing the terminology shift more. And I think 10 years ago, 15 years ago, everybody wanted to blame any kind of liver disease on alcohol.
Yeah.
And it was like, no. There's so many other causes.
Yep.
Like eating and what you're eating, right? Huge changes. America, okay, so then we also look at lipids, right? Or a cholesterol profile. And there's a typical cholesterol profile that people are going to get. And you can get a lot of information from that. So we still get that.
But I think the focus is on the wrong thing.
True. Yes. So regular lipid panel is going to be a total cholesterol, an LDL, an HDL, and a triglyceride level.
Yep.
And really, that's really what's in the basic panel. We also are going to get a few other things, but historically, people have looked at just the total cholesterol level.
Yeah. And the LDL,
right.
And
not the triglyceride level.
and basically like, if your LDL is high, that's, and I'd say loosely associated with increased risk of cardiovascular disease, because in some of these recent meta-analyses that have come out, it's like 70% of people who have a heart attack have quote unquote normal LDL levels. So there's so much focus on that.
There's more to it than just the LDL. Yeah. Like triglyceride level, right? That can be a really
big indicator.
Very overlooked.
Yeah.
So, and HDL.
Unless it's wicked high.
Right.
In which case, then that's something that they'll pay attention to. But, if it's what's quote unquote borderline normal for functional, it's not normal for functional medicine. That's still a sign. Basically, insulin resistance and prediabetes are very much associated with elevation in triglycerides. So if that triglyceride level's creeping up, that's a warning signal.
Time to make a change.
Yeah.
Yep. And there are a lot of easy things you can do. I know my triglycerides were high for a while, and I was like, whoa, hold up. Made some changes, right? And now they're like perfect.
Yeah.
But again, it kind of was like, a wake-up call.
Yep.
Like, wait a second. Nope, you can't be doing that.
And HDL, which was your quote-unquote good cholesterol, that you want to be generally like 50, 60, 70, 80, something like that. Like having a low HDL is also associated with what's called metabolic syndrome, which is that whole kind of cascade of insulin resistance and dyslipidemia, which is like having an abnormal profile. But that so you have less of the sort of protective type of that cholesterol marker, which is also kind of, again, associated with that increased risk for metabolic syndrome, diabetes, heart disease.
Yeah.
So it's worth looking at. And because you can actually see that go up when you're like, they start exercising or they start taking fish oil or whatever, and you actually see that HDL going up.
Totally changes, with diet and lifestyle modifications. So then we also are adding in typically like an LP little a, an apolipoprotein lipoprotein A and B. I mean, some different labs like that that can show some genetic risk factors that can go along, and some inflammatory markers.
And why the apolipoprotein B is not a standard thing. I think it's starting to, because I think even like the American Heart Association, even though they've kind of chatted about it for years, but I know there's probably a bunch of political reasons why they didn't. But the apolipoprotein B is basically, the 2-second synopsis of that is it's a marker for, do you have essentially lots of the dangerous small little, like what they call BB size cholesterol, versus do you have big fluffy cholesterol molecules which are not as dangerous, known to not get stuck in your arteries and
because the little BB ones kind of like clump together and can cause a blockage.
Well, they can supposedly get sucked into the walls of the arteries, the coronary arteries, and your other blood vessels easier, and then they get engulfed by your white blood cells in there and kind of create what's called a foam cell. But they also get more easily damaged. And there's this whole thing called oxidative stress that is well described and written about. And we know that basically that means like whatever kind of other, sort of toxic stuff in the environment you're exposed to, or if you don't have enough kind of natural antioxidant capability of your body, you can't protect yourself, it damages your tissues. And if it damages the cholesterol gets really sticky. And you can actually measure this. It's called an oxidized cholesterol or oxidized LDL. And then find out, like, do you have lots of these big fluffy cholesterols that aren't dangerous, or these tiny oxidized dense ones that are definitely more of a risk factor. And so that ApoB, I think, is when that starts getting up there, you're like, all right, this is the real deal. Like we need to start paying attention to this. Your cardiovascular risk profile is definitely going up because of that.
And then there are other labs that we can do that also we won't talk about here, but that can cause or really show inflammation along the vasculature, the vessels, and stickiness or stiffness of the vessels. So then when you're having, clumping and you're having extra white blood cells and you essentially are building up lumpy roads instead of having nice clean highways out there, it can be an issue.
But the basic inflammatory marker called a high sensitivity CRP or HSCRP.
Super inexpensive.
Yes, inexpensive, very useful. It was like 2000 or 2001, New England Journal came out with a cardiologist written article that the HSCRP was a better risk predictor for heart disease than the LDL.
See, interesting. Yeah, I hadn't read that one. But yeah, I mean, so that's another one that I check all the time.
You're the thyroid queen.
Yeah, so thyroid. So I do a lot of thyroid stuff, and I don't like just checking. I know standard medicine checks just a TSH and then maybe a free T4, but we're missing out on checking the active free T3, reverse T3, and then antibodies. And sometimes you can have a very normal TSH, a very normal free T4, and then normal for standard American medicine numbers, right? And versus functional medicine, we look at a much narrower range. And antibodies might be crazy high, or this reverse T3 might be crazy high, and they can be symptomatic. And again, I kind of equate that back to like, why are we waiting for diabetes to treat, right? Why don't we make lifestyle modifications that can assist us with the thyroid?
So like, for example, say the antibodies, the thyroid antibodies, what does that mean in layman's terms?
Yeah, so if your antibodies are high, essentially your thyroid is being attacked and by yourself. And so you can have a wide variety of symptoms. And it might just start with fatigue, right? So we can have with thyroid, because it really innervates all of your tissues and all of your entire body. And so I talk about either like everything is really hyped up or moving towards being on fire, or it's really slowed down and it's really sluggish, right? And it just kind of depends on what process is going. And you can actually have mixed. So you can have some of these symptoms that are on fire and some of them that are low. And really without like looking at the numbers and then understanding what the cofactors are, like you need selenium, zinc, iodine, the B vitamins, you need all of that to convert TSH to T4 to T3 to be using at the cellular level. And things like stress, infection, exposure to toxins, those can actually prevent the conversion and can prevent the change.
And there's been some really interesting articles about dysbiosis and the alterations in the gut microbiome and how that affects thyroid function.
Huge. I always end up having a gut talk.
Top level journals.
Yes. I always have a gut talk when we're doing thyroid talks. Honestly, it's 100%, food sensitivities can be huge. Anyway, so I check a full thyroid panel every time. Like,
so your theories are basically like if you wait and you're like, oh, we could just wait, and then eventually you're gonna see differences, changes in the TSH.
Eventually,
if you let that autoimmune process kind of go.
Or we support you and support your system, and then all of a sudden everything self-regulates, and you're like, oh wow, I'm feeling better.
Get back into balance.
Yes, you get back into balance, and sometimes it doesn't necessarily even mean like forever vitamin changes, right? Like we talk about dietary things, we can talk about different ways to approach it with exercise. Are you exercising too much? I know you and I have talked about that. Like that can impact your thyroid greatly.
Yep.
So, if you have thyroid antibodies, what are we doing? We need to avoid like raw cruciferous vegetables if we can, and cook them, right? But boil them, bake them, bake. But do you know what I mean? Versus like there's little tweaks we can do that can make a huge difference. And then what kind of B12, are you absorbing your B12? Is your CBC funky and you're not absorbing it because we're not doing the right kind?
Maybe because you've been on an acid blocker for the last 10 years.
Exactly. All those PPIs that we've always said were not but medicine has always just been like, oh, they're okay.
Yeah,
you
no
can
side
be on
effects.
It forever. Yeah.
Meanwhile, you're not absorbing B12, iron, zinc.
Yeah. A
magnesium.
lot of these cofactors that you need to function
in life. Yeah.
Yeah. So anyway, I do a very thorough thyroid workup, and I will just continue to do that because you
picked up a lot of stuff early.
Yes, and people then all of a sudden change it and they feel better. And so isn't that the goal? Mm-hmm. Yeah. Anyway.
And then from a metabolic standpoint too, standard, you check an hemoglobin A1C, and we kind of talked about that a bit already.
Yeah, hemoglobin A1C, fasting insulin.
And hemoglobin A1C is not the greatest screening thing because so what that is, it's a measure of your average blood sugars for the past 3 months, because that's how long your red blood cells live. And if you have a lot of sugar, excessive sugar in your blood that you're not clearing, like if you're pre-diabetic, diabetic, then more of that sugar gets stuck on the red blood cells, and you can measure that, and that's what the hemoglobin A1C is. But again, earlier in the game, it's a rough. There's a utility to it
for sure.
But for somebody who is just starting to become insulin resistant, you might not be picking up anything on that.
Right.
Which is why we love like what's called a fasting insulin or a HOMA score, which is like I forget, it's like a homeostatic metabolic assessment model, I think is what that stands for. And it uses a fasting glucose and a fasting insulin.
Yep.
Easy, inexpensive tests.
Yeah, and insulin is not expensive to test.
Yeah.
Like we can test it. It's like $6.
So for example, just as a 10,000 foot view, if you're like, oh, your fasting glucose is quote unquote normal, it's 99,
right?
But your fasting insulin is 75.
Yeah.
You're like, holy crow, your pancreas is working triple overtime just to try to keep those sugars under control, and you're on the diabetes on ramp.
Exactly.
And we got to change some stuff.
Right.
But
then again, knowledge is power.
Yeah.
Yep. So that's why we
you can't address it if you don't check it.
Yeah, for sure.
And because that is insulin resistance is the it's the root of all evil.
It kind of is.
It's the basis for so many of the health conditions we see. And if you catch it early,
right?
Between 1 out of 4 and 1 out of 5 high school seniors right now, or kids graduating high school, are insulin resistant or pre-diabetic
and don't know. Yeah. No, it's wild. It is absolutely wild.
Yep.
So again, we check those constantly. Homocysteine levels, right?
Yeah, I've been checking that more and more.
I do it most of the time now. I have it kind of on my like general health panel that I do with one of those, especially in my 40-year-olds, 50-year-olds, to get an idea too. And
so it's a metabolic marker that if you don't have enough of what's called the methylation vitamins, so B12, folate, choline, B6 or the active forms thereof. You need those in order for your body to not have excessive amount of this homocysteine to build up. And it's known to be having a little bit is totally normal. Like there's a normal range. And I think like under 7 is fine.
7.5 is usually my okay, here's my goal.
But that metabolite, when it gets high, it's been associated with everything from birth defects, heart disease, cognitive decline, Alzheimer's, Parkinson's, like all these other things. And so again, if you catch this early and be like, ooh, we need to take a look at your diet, or why aren't you absorbing these nutrients, or can we get you these more effective forms of these vitamins or whatever, and watch that number drop, then that is upstream medicine.
For sure. Yeah, for sure. Okay, so then when we talk about like additional testing, I know you and I both do a lot depending on what the visit, because I think at this point we kind of will cater to the N of 1, right? So it's going to be a little bit more individualized because I don't get hormones on everybody. You don't get gut, we both do gut testing, and we don't do it on everyone.
Despite popular belief, I do not test poop on every single
I'll remind
patient.
people of that.
Yes.
But there's a lot, just saying.
Yeah. But I tell all my patients, especially the kids, I get a kick out of it. The poop never lies.
Exactly.
I can do blood work on some people,
Yep.
and the blood work is totally normal. And I'll be like, there's still something going on.
Yep.
The poop never lies, buddy.
Never lies. Yep. Well, and you're right. We pick up a lot of stuff.
Yep.
So I know we only have a few more minutes here. So I was thinking maybe we would jump into just a few little extra non-blood work testing that we often talk about.
Yep.
Kind of like, so like bone density, DEXA testing, you had talked about that. And we don't use it just for bone density. We're also using it, as mentioned previously, for looking at body composition. Mm-hmm. Yeah. And it is worth its weight in gold. I think it's underutilized and yeah. Calcium, coronary artery calcium scores.
Yep.
Again, doing a lot of those.
So this is like a low radiation CT scan that can pick up, because basically, if you have this, your cholesterol and you're starting to get the quote unquote hardening of the arteries, which is what they used to call it. So that hardening is like basically you get calcium kind of gets pulled in where these arterial plaques are, and they can pick this up on these special CT scans, this calcium, and give you like what's called a calcium score. So say if you're like, your cholesterol, your LDL is high, and you're like, am I at risk? Am I not at risk?
Right.
One of the things you can do is get one of these calcium scores. And if your calcium score is really low, it doesn't completely exonerate you. It doesn't take you completely out of the risk pool, but it can be a reassuring factor that you don't have this old plaque built up where, versus somebody who has a really high calcium score. And then they know that, okay, we need to get you plugged in with cardiology and really address all sorts of the, multiple risk factors for that bad happening.
And then we've talked, in multiple podcasts over doing like the VO2 max testing, treadmill testing, like different ways to do more of that metabolic full on health testing and kind of where
and again, not to say that everybody needs this, but some people who want to really want to I need to figure out where exactly am I at, because and I think that we talked about it in the exercise podcast. The number one predictor, I think I just read these meta-analyses that just came out, I think within the past year or two, that the number one predictor of longevity was VO2 max, which is like your which is like either a treadmill or a cycling test that measures your what's called aerobic capacity, how efficient your heart and lungs are.
Right.
It's not a pleasant test.
No.
And you have to be fit enough to do that test.
Right, because you can, it can be adverse.
But or just doing it in the right setting, the safe setting, probably and they, we have like a medical fitness facility right over here that does it and things like that.
Right, and then they're there just in case something happens. Yeah. All right. Well, I feel like that was pretty fast and furious, but if we can wrap up that quick little visit, I thought it was just important that we had that conversation and really talked about some of the different things that we do at a functional medicine visit.
Yeah. More from that, again, obviously N of 1, we very much tailor make all the type of things, but from like a sort of a, how we would view a quote unquote checkup or health assessment kind of involves a lot of those type of things. And you obviously have your DPC, your direct primary care clinic that you just started up as part of Functional Medicine Associates, where it's where you're still being a primary care, but it's that in that type of model that talks about it on their website. functionalmedassociates.com. One of the things that we're also gearing up to offer in the future is group medical visits, where we get a bunch of people with the same concerns, like maybe it's a metabolic health assessment type of thing, and we'll take a group of people, do the education, get the lab testing done, and then
labs done
and then follow kind of follow through on that to explain again just that scaling up of how do we achieve our health objectives to scale. One person at a time, obviously great, but if we can do some of these things at a bigger scale, I think it has far-reaching benefits.
Agreed.
So how do people find us?
Yeah, so you can find us a couple of different ways. We are definitely on social media, on Facebook, Instagram, at functionalmedassociates.com. And also you have a website.
That has links back to this clinic.
Links back, thomasglass.com. So really, you can find us quite a few places. This podcast is available on all the major platforms. Like it, share it, leave us a comment. We'd love to hear what your thoughts are, if there's something you're interested in having us chit-chat about.
And if you like it, please rate us, because I think that helps people find the podcast easier.
True.
And share it with as many people as you can who are interested in overall health and how to better themselves.
Exactly. Yeah, and then we always want to say thanks to Triple Divide Creative, our producer, because she's amazing, helps us out.
Edits out some of our bloopers, not all our bloopers.
Some are hard to find.
Yes.
Yeah. So anyway, thanks again for joining us today, and we'll see you next time.
See you next time.